And so again, a fabulous session on targeted therapies, both EGFR across basically the spectrum, but we also heard about ALK in the earlier stage setting. And so a couple of things to clarify in your talks. One question, Julia, that came up in your talk was talking about plasma and how plasma was a biomarker in the setting of kind of combination therapies. And I know that in these types of forums, we've talked about plasma for a different use before, looking at mechanisms of resistance, et cetera. And just for the context for the audience, can you kind of describe how plasma might be used in EGFR mutant lung cancer and whether or not looking at plasma before treatment is ready for prime time?
Yeah, it's a great question. So when I think about plasma testing, we're talking about when you have your blood drawn and they sequence any tumor DNA that's been shed into the blood, looking to see if they can detect tumor DNA associated mutations. And the ones we're often most interested in are all the various actionable mutations we saw in that pie charts of EGFR, ALK, and others. And sometimes if the tumor is shedding enough DNA into the blood, we can pick them up and identify them. The most classic way that we use this is for initial identification of a mutation. If you're newly diagnosed as part of comprehensive testing, we'll know, do you have a mutation or not in the tumor cells? And while the most sensitive way to do that is on a tumor biopsy, we're actually feeding the tumor cells themselves into the test. The tumor DNA is sort of a backup way to do it in some sense that is certainly less invasive and sometimes comes back faster, but it's less sensitive. The tumor might just not be shedding enough DNA. So it's like it's good to rule in a mutation, but you can't use it to rule out a mutation if it's negative. And that's really how we're using that as part of our standard of care in lung cancer these days. There's a lot of research going on looking at other ways to try to use plasma-based testing to guide treatment decision-making, whether that's trying to understand, can we use plasma to monitor treatment response or monitor risk of relapse, people with earlier stage disease, maybe after surgery or radiation. Those I would consider all to be research questions right now and really exciting areas of research, but not yet part of our standard of care in some sense because we're not quite sure what to do with that information. If it turns positive or negative, we don't yet know if you modify what you're doing based on that information, are we actually having an impact on how people do long-term, or are we just making ourselves feel better because we're changing things, but we haven't changed the long-term outcome? So that research is so important and I think really exciting, but ongoing. Now, the example that I mentioned is maybe a third way to use this, which is trying to risk assess disease and try to figure out, is this higher risk disease where more intensive therapy might be necessary? And again, that's not quite standard of care just now. You're not going to see in the national guidelines, plasma positive EGFR lung cancer, do this. And the clinical trials that I mentioned weren't designed to kind of ask and answer that question. So it's what's called a subgroup analysis, where they look back and you kind of slice and dice the data a little bit and say, does anything we could see in there seem to predict for more or less benefit? And then can we try to use that in real life as one factor among many to guide our conversations about this? So for me, I like using that as one piece of many. And I do like knowing my patient's plasma status for EGFR at diagnosis, if possible, because I know that people who are plasma positive, in general, it correlates with a higher burden of disease. And it also tends to correlate with kind of more likely to have brain metastases. Not that that's a causative thing, but just that it goes along with cancer that's a little more extensive at diagnosis is also a little more likely to have brain metastasis. Now, your plasma status is not essential. I think your oncologist can also look at your scans. I think we can all recognize when it looks like a scan, unfortunately showing a little more extensive disease than we wish, or where our patients are sicker at diagnosis than we wish they were. Maybe their cancer's a little more in more places at initial identification. So it's not required, but I find it helpful just when I'm trying to quantify, one factor again among many in risk assessment.